weekly or semi-weekly core seminar series. It's good to have a nice group of people here. And today it's my pleasure to introduce Dr. Jesse Papenburg. He's an FRQS scholar, a pediatrician, and an expert in the area of respiratory viruses and their epidemiology. So without further ado, I will pass it to Jesse.
Well, thanks so much for having me. It's actually, I was just mentioning, it's only the second time that I've been in this building. It's really nice. But it's a 15-minute walk from my office at the Glen over in the RI. So I don't really know this group that well. I'm sure if I saw your names, I'd recognize more of you, but I have had a chance to work with some of you. And I do hope that perhaps you'll come out of this talk at least mildly entertained. But I'm going to be talking to you about one of my research foci, which is on the diagnostic side. I am a microbiologist, so I do some of my clinical work in the clinical diagnostic lab. But also I'm a pediatrician and infectious disease specialist, and you'll see that I think that respiratory viruses play a huge role in our day-to-day work at the hospital. So these are my conflicts of interest, and some of these are commercial entities that I've had some sort of relationship to who, and I may be talking about some of their products, but it's also a way to slip in gratuitously, I must add, a picture of my son having fun in the sun, and let's just leap into it then. So I'll touch a bit on the disease burden of respiratory viruses in pediatrics and adults. And then we'll really focus on rapid diagnostic testing, as we've done some work in terms of the accuracy of rapid diagnostic methods for, I think, the two most important pathogens in terms of respiratory viruses, RSV and influenza. And I'll share with you a little bit of work on some of what we're learning from our experience in the diagnostic lab and with our patient populations at the MUHC. So acute respiratory infection is really the most common acute illness regardless of age or gender. And we know that more severe disease leading to hospitalization can manifest itself in young children, particularly as bronchiolitis in infants, pneumonia. But in high-risk adults and in the elderly, you'll see a lot of exacerbations of underlying chronic disease like COPD, asthma, or even cardiac disease. There was a recent publication in the New England Journal, actually, from a group at ISIS in Ontario, where they showed, I think it was a 6- or 7-fold increased risk of MI in the 2 weeks following diagnosis of influenza infection. It's the second leading cause of death in children less than 5 years old across all regions of the world. And really, most respiratory infections, acute respiratory infections, are caused by viruses, especially in kids. So when you look hard enough, and this is a prospective cohort study that we did in Québec City, looking at a group of hospitalized children with acute respiratory infection less than 3 years of age, and a group that presented at the Sainte Foy Pediatric Clinic, which is the big pediatric clinic in Québec City, with signs of a lower respiratory tract infection. And what we found was that really, among those, overall, over 85% had at least one respiratory virus in their nasopharyngeal secretions associated to this illness. And the major player in pediatrics certainly is RSV, respiratory syncytial virus. And in our cohort, almost 2/3 of those hospitalized had RSV infection, and about half of those that were presenting to the clinic also had an RSV infection. Human metapneumovirus is a relatively new player. It was discovered in 2001, and it's a common cause of bronchiolitis in young children. Influenza was perhaps less important these years that we happen to be doing the study, but I'll just note that we were not able to run the study during the 2009 pandemic because of resource allocation. We were being pulled in other directions, and we had to hold off on the study during that period of time. And there are other viruses, adenoviruses, coronaviruses, enteroviruses are a common cause of acute febrile illness in young children, and the parainfluenza viruses, which tend to cause croup. RSV, I'll just say one word. It's a bit of a frustrating disease because it's such a huge burden in children, and you'll see in adults as well. And really, there's just not much we can do other than supportive care for the moment. Although there are new antivirals that are in development and look quite promising. And in terms of prevention, we've been stuck with this very expensive and difficult to administer monoclonal antibody that needs to be given once a month and only to really targeted high-risk children because it is an expensive intervention. So palivizumab has been shown to reduce the risk of hospitalization by about half in these high-risk kids, but it really only covers a small proportion of the population that gets into trouble with RSV, as most of the kids that are hospitalized with RSV are actually otherwise healthy infants. But there are now vaccines that are in phase 2 or phase 3 development targeting either pregnant women, so a passive transfer of antibodies to the infant to protect children less than a year of age from RSV disease, as well as active vaccination for the infant themselves. And there are also vaccines now being developed for the elderly for RSV. Now, not to belabor the point, but really RSV in this prospective study that was published in 2015 by the CDC on community-acquired pneumonia in children, RSV was the #1 identified pathogen. And what that translates to in the United States every year is about 2 million outpatient visits in kids less than 5 years of age and 50,000 hospitalizations. And worldwide, it's a leading cause of pediatric mortality. And when we compare RSV to influenza, because that's typically what people think of when they're talking about respiratory viral infections, overall, the rates of hospitalizations are across all ages are equal, but when they're lumped together. But you can see that the age distribution is quite different, with RSV being, this always strikes me, at 2% of children every year less than 1 year of age will get hospitalized for an RSV infection. Whereas the disease burden of influenza is much more heavily weighted towards the elderly. And we've recognized, I think, that we still don't have a good handle on the disease burden of RSV in adults, because up until more recently, with more advances in molecular diagnostic testing and multiplex PCR panels, people weren't recognizing that adults were being admitted for COPD in large part because of RSV infections so as we get to know RSV a little bit better, we've realized that in adults, it really is an important cause of pneumonia, COPD, asthma, CHF exacerbations, and even during peak influenza periods, you still get a proportion of people hospitalized for RSV in terms of respiratory infections, especially in the elderly. And that translates to, in the elderly in the United States, over 177,000 hospitalizations per year and 10 to 14,000 deaths. Influenza, I'll talk a little bit more briefly because I'm assuming that most people know, but that it is a serious public health concern. We talk about 5 to 30% of the Canadian population each year that gets an influenza infection. The higher proportion is more frequently it's in the younger patient population. But that, which at least the Public Health Agency of Canada has done some modeling work to estimate that influenza causes about 180,000 emergency room visits per year in Canada, 12,000 hospitalizations, and over 3,000 deaths. Vaccination, I'm sure that you've all heard about the yearly influenza vaccination campaigns, and there's been a lot of controversy as to how effective these vaccines are and whether repeated vaccination, particularly in young, otherwise healthy people like healthcare workers, whether that has an effect on vaccine efficacy. I'm not here to talk to you about that, but I just wanted to point out that the people in whom the vaccine is needed most are actually the populations in which it works the least well. So very young, it's not even available for children under 6 months of age. And we know that infants and children less than 2 years of age don't respond as well to the vaccine. And then the elderly as well. Here it's qualified as 65 and older, where the vaccine is less immunogenic. So that concept of immune senescence, if you will, does play a role here as well. And I just want to bring up, we have identified over the years high-risk groups, so populations with chronic comorbidities or who are pregnant. not considered a chronic comorbidity, who are at higher risk of having a complicated influenza infection, so either requiring antibiotics for a secondary bacterial infection or requiring hospitalization. And I think it's important that, because many of these patients, at least in terms of numbers, don't have good coverage by the vaccine, and vaccines have variable effectiveness from year to year. There is certainly a role to be played in diagnosing influenza accurately and being able to administer antivirals to those patients who really would benefit most, and they're the ones who fall into either this category or that don't have any comorbidities but who are sick enough to get hospitalized. And the tricky thing about respiratory viruses is, even though there is such a thing as influenza-like illness, which can be defined in various ways, but usually it's some sort of combination of fever and or a sore throat or cough or muscle aches, fatigue. CDC has one particular definition, but there are other definitions out there. But even during peak influenza season, the diagnosis, the definition of ILI only has a positive predictive value of about 75%. In other words, if you use a syndromic based diagnosis like ILI, you're going to definitely be over-treating a lot of patients for influenza, and you're going to be missing a lot of cases as well, particularly in pediatrics, because young children, like the elderly, manifest their infections in very non-specific ways. So it can be difficult to diagnose on clinical grounds alone, and impossible to differentiate from the other respiratory viruses that are circulating, or perhaps even more importantly, trying to differentiate from a bacterial pneumonia that happens to be either superinfecting the viral illness or just a purely bacterial process. And amongst hospitalized patients, 30 to 50% of adults or children who have RSV or influenza are going to have X-ray abnormalities or pneumonia-like findings on their chest X-ray. Now, are those chest X-ray findings simply due to the virus, or are they due to a bacterial superinfection? We know that Streptococcus pneumoniae, Haemophilus influenza, they can cause a bacterial infection on top of your viral illness. But how do you distinguish the two is really one of the crux of the problems that we have. All this to say is that lab diagnosis is necessary to be able to confirm the presence of a respiratory virus. So which leads us to respiratory virus rapid diagnostics. So why has there been a push towards rapid diagnostics in terms of in viral respiratory disease? Well, it's really thought that if you can identify a virus as the potential cause, or at least associated with this acute respiratory infection that's in front of you, that should decrease the likelihood that there's a bacterial infection here. So what does that mean in terms of consequences? Well, hopefully it'll mean less unnecessary antibiotic use, and this is really what we're all aiming for, and that has, I think, the greatest potential public health implications. Antimicrobial resistance is certainly a public health priority, whether it be the WHO, the CDC, PHAC. Everybody is trying to limit unnecessary antibiotic use, because it is this unnecessary antibiotic use which is going to drive antimicrobial resistance and not produce any benefit for either the individual patient or society as a whole. And antimicrobials are unique in the sense that they modify future risks of not only that one patient in whom you're prescribing the antibiotic. So if I get prescribed an antibiotic and I take it, I'm certainly selecting out for more resistant organisms that are on me. But also they modify the risk for the population as a whole. So the more antibiotics that you prescribe at a population level, now whether that population level be your ICU, your hospital, or your province, we know that is associated with increased antimicrobial resistance and transmission of antimicrobial resistant organisms horizontally. So that is really what we're aiming for, but I'm not sure that we're actually there yet, and that's what we're going to be talking about a little bit later on. Prompt initiation of antiviral therapy, certainly for currently, we're only talking about influenza, and we're really only talking about the patients who are at higher risk. So the guidelines for influenza antiviral therapy, they don't say to treat everyone you think that has influenza, or even everybody that you've diagnosed with influenza. I'm not sure how familiar you are with the literature or the controversies surrounding Tamiflu, for instance, and its efficacy. But if you boil it down, it probably comes oseltamivir, zanamivir. They probably confer a benefit of about 24 hours of symptom reduction or fever reduction in otherwise healthy patients who are just presenting to an outpatient clinic. And that's in the patient population in whom the drugs were studied in the randomized trial setting. Also in children, same thing, about 24 to 36 hour reduction. There are some meta-analyses of these trials that have shown that antiviral treatment also probably reduces complications requiring antibacterial treatments. So sinusitis, ear infection in pediatrics, pneumonia, and that's from the randomized trial data. But that's it. And most of these people are not the people that the drug is public health is pushing us to use the drug in. What we are proning using the drug in the more severe cases, so hospitalized patients, never been studied in a randomized trial design, and also in the high-risk patients, many of whom were excluded from the initial randomized trials. So we're really left with a lot of observational data to try and see what are the perhaps more important benefits of antiviral therapy for influenza. And the observational data does certainly suggest that in hospitalized patients, you can reduce serious outcomes such as mortality, ICU admission, or mechanical ventilation when antivirals are administered early. And the same thing was similarly in the outpatient fashion. The earlier the drug is administered, the more likely there's going to be a positive effect and the more of a positive effect there is. Because once the patient presents to the clinician, there's already been a lot of viral replication, and you may even be getting close to the peak in viral replication. So the idea is the sooner you identify influenza and the sooner you treat, the earlier you are in that curve of viral replication, and there's a better chance that you can halt it before it reaches its peak, and a lot of the downstream inflammatory effects have already taken place. From an infection control point of view, identifying which patient has which virus has been used to cohort patients with similar viruses together. And that's no longer the case at the MUHC, since we all have, it's all single-bedded rooms. But our infection control officers swear by the importance of identifying respiratory viruses in the hospitalized patients because they do want to know about outbreaks that are taking place, particularly among the high-risk populations that are hospitalized. There is some observational data to suggest that when these rapid tests are used in the emergency room setting, that you may actually reduce the need for hospitalization. If somebody sees that this acute febrile illness is due to influenza, they may not hospitalize the young baby due to it, or same thing for elderly patients. Or maybe shorten the length of stay in the emergency department. So how we implement these tests can have a big impact on what their potential benefits are. And finally, if a patient is being worked up for a suspected bacterial process at the same time as you're looking for respiratory viruses causing their syndrome, well, if you get the virus result back fast, or almost within the first patient encounter, maybe then you don't need to do that chest X-ray, you don't need to do the blood culture because you know it's RSV. And you know that in certain populations, the risk of a secondary bacterial infection with RSV is quite low. So this is just kind of summarizing what we were saying before in terms of, well, the first thing we need to understand about these tests is, well, what is their diagnostic target and how good are they at classifying disease versus non-disease? And if the clinicians don't trust the test result, then obviously it's not going to have much of an impact on their decision-making downstream. So if the test lacks sensitivity, people might still prescribe antivirals even though the result was negative. Yes, of course. Please interrupt me. I feel like I've been going on and on and on.
So in the adult side, irrespective of epidemiology,
That's absolutely. I agree with you 100%. I think that these tests have for many years been kind of sold as a way to, yeah, and yeah, and there's very little RCT data to try and help us with, to say, can it really have that type of benefit? Because as you point out, it may not be the infection per se that's causing the hospitalization, but the need for supportive therapy that's causing the hospitalization. Perhaps IV antibiotics is that one thing that you might say that, oh well, if I don't need to admit for IV antibiotics, then I might not need to, or might not need to hospitalize. So, and in pediatrics, the less than 90-day-old infant population, where really many of these infants, if they don't have a virus identified, you kind of have to assume it's a bacterial infection until proven otherwise. In other words, until bacterial cultures have remained negative for 48 hours, and those cultures could be blood culture, lumbar puncture culture. So these patients can get hospitalized on empiric IV antibiotics and really just waiting out that 36-48 hour window period until just for fever, and not necessarily because they were so sick that they required IV hydration or respiratory support. So that might be a particular patient population in whom it could be helpful if identifying a virus truly does modulate your risk of, or lower your risk of a bacterial infection. So that's a great point. But I think that, so in terms of patient management, really what we would hope for is decreasing unnecessary antibiotic use, decreasing ancillary testing. That rapid antiviral therapy is going to become even more important once we have drugs for RSV that are available. Certainly in pediatrics, if we do have an effective drug for RSV, identifying RSV will be much more, I think, significant. We talked about cohorting, and then everything else. It's been postulated and sometimes analyzed in cost-effectiveness studies, but nobody's really demonstrated that identifying viruses, especially not in rapid test setting, really does decrease return visits. So it's been hypothesized that if a patient knows, or if a parent, let's say, knows that their child wasn't just told, oh, it's a virus, don't worry about it, but your child has RSV, there may be increased satisfaction in terms of the medical encounter. And there may actually be less of a chance that the patient comes back 24 hours later because they still have the same symptoms that brought them in last time. But we don't really know that. Length of stay, perhaps in the emergency room, yes, but in hospitalization, I don't think so. Decreasing the risk of hospitalization, great points were brought up. Cost, perhaps. And then downstream complications, increasing survival, decreasing transmission of either the virus or the antibiotic-resistant organisms, and decreasing antimicrobial resistance. This may all be pie in the sky right now. It's what people have been really kind of thinking as a motivation for testing, but I'm not sure it's the case. So, but I think that speed does play a role, because if all the decisions are already being made by the time that you get your test result back, well, if you've already started the antibiotics and then you find out a day later that there's a respiratory virus and your patient is better, is it because it's a respiratory virus and the patient was supposed to get better anyways, or is it because my antibiotics are working and that's why I need to continue the antibiotics? So that's why people have been trying to develop rapid tests for respiratory viruses for quite some time. And ideally, the turnaround time of that test would be within the time of that initial clinical encounter, either an outpatient setting or in the emergency department. And obviously, the complexity of a test is what determines where it can be done. In the United States, the FDA has something called a CLIA waiver, and CLIA waive tests are low complexity tests that don't need to be performed by a lab technologist and can be performed outside of the lab setting. So you can think of things like a blood glucose that's done at the bedside, a home pregnancy test. These are examples of CLIA waived tests. And all of the rapid tests that we're going to be talking about have received CLIA waivers, so they're considered simple enough they can be performed outside the lab. The standard gold standard. Yeah, what was long considered the gold standard for respiratory virus diagnostics was cell culture. Problem with cell culture is you need to grow the cells, you need to propagate the cells. It takes days and sometimes even a couple of weeks before you see a cytopathic effect and confirm the presence of respiratory virus. You need specialized lab equipment, specialized personnel, and it's not even that sensitive for a gold standard compared to the newer molecular methods, but it is highly specific. There are ways to detect viral antigens, either direct immunofluorescence, which is really the technologists love doing direct immunofluorescence because you take the specimen, you put it on a slide, you put some antibodies, incubate it, and then if the specimen, you look at it under a fluorescent microscope, and if there is the virus in question there, the antibodies have bound, you get this beautiful apple green fluorescent stains specific to certain parts of the cell, depending on which virus it is. But all this, even though the test itself only takes 2 hours, it does take quite a bit of technologist time. So it's a labor-intensive, and you need specialized techs who are used to seeing it to be able to interpret it properly to have good accuracy. And even in the best hands, it's still not as good as molecular detection methods. And there have been the rapid antigen detection tests that we'll focus in on a bit more that have been around since the 90s, and they have very variable sensitivity. So PCR and other nucleic acid-based amplification tests are the gold standard, and up until they have very excellent analytical sensitivity. In other words, they can detect a small amount of virus in a clinical sample, which translates into great clinical sensitivity. So they'll be able to detect the disease state to the best of our abilities, at least. I'm not saying 100%, but very high sensitivity and very high specificity. Up until recently, all of these molecular diagnostic tests were very complex, could take 18 hours of lab time just running the test. You need to have specialized equipment that is expensive. They need to be run in batches. So the turnaround time of the test, even the quicker ones that may only take an hour and a half to 3 hours, by the time the specimen gets sent to the lab, batched, and the results get reported, we talk maybe over 24 hours. And serology is just useless because we're exposed to respiratory viruses all the time, so you need to do paired sera, so at least 2 weeks difference, so well beyond clinical utility. So these rapid antigen detection tests, and we'll talk first about RSV, this is one example of an immunochromatographic assay, similar to your home pregnancy tests. And these were around since the 90s, and interestingly, certainly in Canada, nobody really uses them in outpatient clinics, which is where they were being marketed for initially. Why? Because in our healthcare system, who is going to pay for this test? So physicians don't want it to come out of their pocket. Now we're certainly not allowed to charge patients for it. So who has been using it, both in Canada and also in the United States, are a lot of labs that are not very specialized, labs that are not part of the university health center. So they want to be able to offer results to their clinicians, whether it be for RSV or influenza, but they don't want to have to send it from Rimouski to Quebec City in order to get a result, because they know that's going to take an add-on 2 days of turnaround time. So these rapid tests are really they're fast, less than 10 minutes. They're approved for use at the point of care. They're so easy, even a doctor could do it. And the major problem, though, was that they did lack sensitivity. So knowing that they lacked sensitivity, as part of one of that cohort in Quebec City, we had the clinical test that was being used for RSV at the time was one of these rapid tests, the Binax now. You can also see from the image, it is a visual read by the operator, the technologist, so it's kind of like, well, is that second line there? Do I really want to be pregnant? There is some subjectivity in the reading of the test as well. And we compared it to this monster on the right, which I think took something between 18 and 24 hours, but is a DNA chip. It's a PCR based, but then DNA hybridization. It was not a bad research tool, but it never made it as a commercial assay. So what we want to know, well, what are the factors that are associated with having a false negative test? In other words, what is driving that lack of sensitivity? In our cohort of 720 kids that were admitted for acute respiratory infection to the CHUL in Quebec City, in whom we knew that almost 2/3 were positive for RSV by a reference standard. And so what we found is that something that's pretty similar to what's been seen elsewhere in the literature, sensitivity 80%, specificity was much better. which led to a great positive predictive value, but negative predictive value not so good. And if you look at the likelihood ratios, obviously the positive likelihood ratio is great. You know, it helps you say this patient does in fact have RSV. It doesn't really help you rule it out with a negative likelihood ratio of 0.2. But then what we did is so if you look at these columns, really, it's just if the proportion of true positives that were identified by the index rapid test. So in other words, this proportion is actually this clinical sensitivity. And what was most striking to us was how the sensitivity went from 84% in kids that were less than 3 months of age. But once you got into the third year of life, sensitivity dropped down to 60%. We also found that symptom duration was associated with increased symptom duration was associated to risk of a false negative. Pneumonia in univariate analysis was associated with a false negative, and RSV genotype B seemed to be less well picked up by this particular assay. So then when we did a multivariable logistic regression model, obviously age remained an important independent risk factor for a false negative. What was interesting is that pneumonia actually wasn't really considered to be a significant risk factor. And that's because kids who were older were being diagnosed with pneumonia, whereas the younger kids tend to be admitted for bronchiolitis. So it was really confounding by age in this particular case. But yeah, I guess the so what is that I think that obviously clinicians need to be aware of these, of who is at higher risk of having a false negative result. But perhaps maybe more big picture is that the CDC surveillance for RSV, at least up until even in this past year, most centers that are submitting data to the CDC are using rapid antigen detection tests. So when we're trying to establish what the disease burden of RSV is, we're missing probably 40% of the kids who do have RSV who are being admitted in that third year of life. So we're underestimating disease burden in older kids based on the type of tool that was being used. Yes? This is the risk of having a false negative. So in other words, the risk of being negative when the reference standard was positive. Yeah. Amongst them, yeah. Who is being missed by the Binax now? Oh, so initially it did include it in the model because we thought that certainly it's been in adults this may be more true. It was thought that once the infection does migrate from the upper respiratory tree to the lower respiratory tree, then perhaps you're missing it because the sample is coming from the nasopharynx. But what I think it was in pediatrics is that it's not the clinical syndrome of pneumonia that's really causing a false negative. It's that children the most common cause of hospitalization in children less than a year of age is bronchiolitis, not pneumonia. Whereas as kids get older, their bronchioles become bigger and they don't run into this problem of small airway disease, bronchiolitis. If they're getting admitted, it's because they have a pneumonia, either clinically or on chest x-ray. Yeah, yeah.
So that 1.3 now, you have a confidence interval of 0.83 to 0.3.
Yeah.
So that's increasing. There could be up to a two-fold increase, or there could be like a marginal.
Yeah.
So, because I think we often do this, like we see that it's not conclusively positive, and then we come up with a physiology, which is great, but you could still conclude that the pneumonia is, I think it's already not a great.
Yeah, it could be, and I think that certainly again in adults, I think there's more of a rationale as to why that might be the case, because adults tend to be before they present, they'll take a little bit longer, they'll grumble along, and then they're kind of whatever it is that their underlying comorbidity is starts to decompensate, and they come in, and at that point, it's true that especially if it is a true RSV pneumonia, the virus may be at lower titers in the upper respiratory tree compared to the lower respiratory tree. And the problem with these tests is that they were missing the lower titers mostly. So if you do like try and do a quantitative analysis of how much virus it is, it tends to be the samples with lower amounts of virus that were missed by these tests. Not conclusively, but certainly as yeah, I sold it pretty well, but I'm not sure. I think that there is some evidence to suggest in certain cases that's true, where we do have, for instance, a BAL that will be positive, but an NP sample that might be negative. But now that we're using PCR, we'll find it in both. Yeah, yeah. But with these lousy older tests, we might miss it in the upper respiratory tree. I don't know. Is there? Are you a respirologist or a? Yeah. Okay. So I gotta watch what I say. If I'm talking pulmonary physiology, I'll keep it simple. So then we want to see, well, is this kind of true across the entire category of tests? So we did a systematic review and meta-analysis, and I didn't actually make up these numbers, even though they are exactly the same as our primary study. But you can see there is quite a bit of heterogeneity across tests. But overall, we wound up with that type of similar types of performance characteristics. But I think what was interesting from that study is we were finally able to pool enough data from adults and compare it to children. And clearly, you should not be using that test in an adult because you're missing 70% of your cases. So what is the point? We used different reference standards. We allowed for different reference standards, including PCR, immunofluorescence, viral culture. And not surprisingly, if you chose a reference standard that's not as good, your index test tends to look better. So when you're using PCR, it had a lower sensitivity than if you were using other methods. Studies that were sponsored by industry had about a 10% better estimate of sensitivity compared to those that didn't have any or didn't declare any funding or sponsorship. And that was not completely explained, but perhaps partly explained by the fact that the industry-sponsored tests tended to use less PCR, but that wasn't a statistically significant difference. But the way that the FDA regulates new diagnostic tests is that you just have to compare it to a accepted reference standard, at least at the time for these tests. So it was okay for these studies that were being used for regulatory purposes to compare a rapid test, new commercial rapid test, to viral culture, and they weren't forced to be comparing it to PCR. That's changing. Okay. So now, if we switch gears to influenza, and now there are these newer rapid diagnostic tests, and I'm talking about influenza because that's what we studied, but they exist also now for RSV as well. And these are immunoassays, but now that have an automated reader. So you're no longer visually trying to interpret that second positive line. So they should be more objective. And there have been improvements in the chemistries as well that the manufacturers proposed, which should increase the sensitivity of these tests. So the manufacturers are trying to say, look, this is back in like 2011, 2012 when they came out. This is not your father's rapid test, okay? These are the newer, better rapid tests, much better. But you do have to buy a little instrument to be able to run them, so that's added costs. But what was perhaps more exciting is that there have been advances in molecular diagnostic techniques that will actually allow for molecular-based tests to be done outside the lab, and also in a time frame of we called rapid for our purposes of our study less than 30 minutes. But for instance, the Alere product was the first ever CLIA-waived molecular diagnostic test, and it happened to be for the one for influenza, and it uses a nicking enzyme amplification reaction, which is a isothermal technique for nucleic acid amplification. Who cares? I mean, it gives results in less than 13 minutes, but the way it was able to get these results is you don't have to go through the thermocycling. I don't know if any of you remember PCR from your medical school or undergrad, but has to go through different temperatures for the different parts of the reaction to take place, and then you can then amplify the targeted nucleic acid sequence. So this allowed for it to be done at a single temperature and much faster. And then Roche bought a product that was called by LIAT, which stands for lab in a tube. It's actually a modified real-time PCR, but the cute thing about it is the reason it's able to give results in less than 25 minutes as opposed to the typical 90 minutes for a PCR reaction is that instead of having a block heater that needs to change temperatures for it to change the temperature of the specimen in order for the different parts of the reaction to take place, the specimen gets shunted to different parts that are at a different temperature already. So that's how it's PCR, but just a little bit sneakier or faster. Whereas this is completely a different method. So those products came out 2011, 2012, 2013, just at the time as everybody was realizing, wow, these old influenza rapid tests are really lousy. There was a systematic review that was done by Carolyn Chartrand, and who was working with Matthew Pai in his for her master's thesis, and they showed that comparing the rapid tests for either to PCR or viral culture, they found that the old ones had poor specificity overall and poor sensitivity overall and sensitivity of about 53% in adults. So these new tests came on the market, and at the same time, the FDA was reclassifying influenza rapid tests and now imposing minimum performance requirements. So not only did we have these new tests that were on the market that had been there long enough that there were enough publications to be able to pool the data, but we really had this impetus from an external pressure that people want to know, well, how good are the new tests? Because I'm not going to be able to use my old test anymore, probably. So that's that we did actually an updated meta-analysis of the previous Chartrand study that was just published last fall in Annals of Internal Medicine. And that was done by Joanna Merks, who was at the time a master's student here, and I worked very closely with Nandini on this project. Systematic reviews, they're different from primary studies, and it does take, there is, I think, intellectually different challenges, but perhaps not as glorious as a primary study that's going to wind up in a high impact journal. But it was a lot of work, and really it was fun to work with these people. Now it all seems like fun, but I don't know if in retrospect it seems like it was fun. So our objectives were to estimate and compare the accuracy of commercialized, what we call the traditional rapid influenza diagnostic tests, the digital immunoassays, which are the ones with the automated readers, and the rapid NATs, the nucleic acid amplification tests, for influenza A and B in clinical specimens from patients with suspected influenza, compared to, here we really restricted to a lab-based PCR reference standard. Yep. So a NAT is really like just a PCR is a type of NAT. So PCR is a method to amplify DNA to detect it, or RNA. Where NATs are just saying there are lots of different, like the isothermal method that I was talking about earlier is a type of NAT, yeah, but it's not PCR. The PCR is largely considered the best studied and the most accurate, and it's typically done in the laboratory setting. And in this case, it was always done in the laboratory setting. And we want to determine factors that could be associated with test accuracy within each of the different 3 rapid test classes. So we really decided to analyze each class of rapid tests separately because it made no sense to pool their data. So we use the typical methods in terms of developing our protocol, our analysis plan. We are not going to present the quality data, but we did analyze. We did look at the data of the literature to assess the risk of bias. We pooled our estimates across studies with Bayesian bivariate random effects models, and we had a priori subgroup analysis that we thought where there could be differences in test sensitivity. Most importantly, patient age, we thought, and point of care testing. So is the test being used in the lab or is it being used out in the field? Commercial brand and industry sponsorship. And we were lucky enough to get the EndNote library from Chartrand, and we tried to base our case report or our data extraction form loosely on what she had done as well. So we used their data, so it kind of increased our efficiency, but we excluded all the studies that used viral culture as a reference standard and only included the ones that included PCR. And then we went through all of our screening and assessment for eligibility and wound up with 116 articles, but 162 comparisons of different commercial rapid tests to a PCR. And we also decided to exclude studies that didn't present separate data for influenza A and influenza B, because some papers would just report accuracy for diagnosing influenza, but really it is two separate diagnostic targets. They have different population mixes, different importance in different populations. So we thought we really wanted to look at each of those two targets separately. And just to give you a sense of amongst those 162 studies, 130 were the traditional rapid tests, 19 were DIAs, and 13 were rapid NATs. And our primary results, what we found were, not surprisingly, the traditional rapid tests were not good overall, with sensitivities around 50%. The DIAs were better, 80% overall for A and 77% for B. So just kind of at that cusp of what the FDA is going to consider a minimal performance requirement. And the rapid NATs were clearly superior, and these differences were all statistically significant. And really, if you're talking about the rapid NATs versus traditional rapid tests, it's about a 40% gain in sensitivity, a 40 percentage point improvement. But the difference between the rapid NATs and the DIAs is not as impressive. And all specificities were excellent, so we didn't do any further analyses on specificity, as they were always very good. Patient age, as I mentioned, was really our most important a priori subgroup analysis, and what we found was that the traditional test should not be used in adults, with up to only 1/3 of true positives being detected for influenza B. The DIAs performed well in kids, certainly above 80%, and I think they're relatively cheap. They can be done simply. If your patient population is children, I think you can say they perform well enough to be used, but not so well in adults. I should mention that our study was sponsored by an investigator-initiated grant from Becton Dickinson, and BD Diagnostics makes one of the two DIAs, which I don't know if you've ever had an experience working with industry. They were very hands-off and really didn't have anything to say about either our analysis plan or our protocol, the way we analyze the data, where we submit it for publication. They asked to look at it, but they didn't, and they gave some comments, but I was free to do whatever I wanted. What I found tricky was not, the results were the results, and we had our a priori analysis plan as well. What was tricky was actually writing the discussion. I was cognizant of the fact that where the money was coming from, and I didn't want to look as if I was, over spinning positively for them. But I also didn't want to knock them down just because I wanted to look impartial. So I would say that was the tricky part in that experience for me. And then the rapid NATs overall did great in kids and not so well in adults. But we only had 4 studies that had adult-specific data for the rapid NATs, and 3 out of those 4 were the isothermal method and not the modified PCR, which you'll see is important because there wasn't really any true clinical or statistical difference between the 2 DIAs, commercial brands, but the isothermal technique did not perform as well as the PCR-based method. The difference of about 12 percentage points between the 2. BD does have a NAT, but it's a lab-based assay, so it wasn't analyzed. We didn't see any differences whether the test was performed at the point of care or not, but we didn't have any data on the rapid NATs at the point of care. There just had been no studies published on it. Industry sponsorship. Interestingly, there was always a difference that tended to favor industry-sponsored studies, and depending on the subgroup, it would be significant or not. And you know, there's there are a lot of reasons why that's true. I think part of it has to do with industry-sponsored studies, are especially with the newer products, are the studies that were used for regulatory purposes. So really well done studies that where people are being paid to do the test, and it's not like if I'm evaluating a test in our lab with one of our technologists, and that technologist has to run something for the clinical lab, then come like, okay, I'll do one rapid test now, or I've got to go do this. So I think the adherence to protocol in the industry-sponsored studies is probably greater than some of the independent evaluations. But on the other hand, you might say, well, these independent evaluations are really perhaps the real-life accuracy of the test. So I think there's still some work to be done trying to understand what's driving these differences that we've assessed. So you could argue that perhaps the industry is going to decide to evaluate their tests on kids because they know that sensitivity is going to be better in kids. And why is sensitivity better? Is because children shed greater amounts of virus for a longer period of time than adults who have seen influenza or RSV in the past that have some level of cross-reactive neutralizing antibodies to diminish the viral load in the secretions. Yes. Yes, no, we excluded any case control studies where you had patients that were being tested, the asymptomatic patients being tested. It was all specimens had to be on patients with suspected influenza clinically. We did a sensitivity analysis acknowledging that not all PCRs are necessarily created equal, either among commercial assays or lab-developed assays, and it might not be a perfect reference standard. And what we found was, yes, our estimates for the index test did look better when you relax the assumption of 100% sensitivity, 100% specificity of the reference standard. But overall, our conclusions remained the same. So I think we talked about our limitations already. And really, you know, the older tests now, they're going to be on their way out. And now we need to see that. So we saw that age was an important effect modifier of test accuracy, and DIAs performed well in children, but maybe not in adults. And the rapid NATs certainly met the new performance requirements. And now we need to focus efforts on who should these tests be used on, in what is their feasibility at the point of care, what is their performance at the point of care, and what is their impact on clinical outcomes. And there was this editorial by someone saying, this is fantastic, now we've got these new tests, we've got to use them. I'm not so sure. Perhaps use them wisely in the patients who need them most and whom you're going to be prescribing antivirals. Because I guess I'll have just maybe a couple of minutes to talk about some of the work we've done at the MUHC, not on rapid testing, because we don't use the rapid tests here, but how does respiratory virus diagnostics impact patient care? And we do over 10,000 respiratory virus tests per year, so we're dealing with a big volume. So we can't use these one test at a time methods. We have to use batches, and we run several batches per day. In the wintertime, that's going to be 4 to 5 runs in a day. And our mean turnaround time, if the specimen's coming from the Glen, is about 8 hours during influenza season. And we have 12 targets, which include RSV, flu A, flu B, but other respiratory pathogens we've already talked about. So in pediatrics, I mentioned that the number one cause of hospitalization in children less than a year of age is bronchiolitis. And the American Academy of Pediatrics and the Canadian Pediatric Society both say, don't test for respiratory viruses in bronchiolitis because you know they have a virus. Bronchiolitis is a viral syndrome. The patient has respiratory virus written on their forehead because it's a clinical diagnosis of bronchiolitis. And one of our pediatricians wanted to do a Choosing Wisely campaign, or at least a quality improvement initiative, to decrease the amount of testing that was being done, because it can be fairly invasive. It's not cheap, $55 a test. And what are these results helping the patients? But there was pushback from the pediatrician saying, whoa, don't take away my test. I like it. It helps me make decisions. I want to know what the patient has. So we looked back at children less than 2 years of age over 2 winter seasons, admitted with bronchiolitis, using the discharge summaries as our way of identifying our patients. And our hypothesis was that respiratory virus testing is not going to make a difference in this patient population. And we want to look at the impact of our multiplex testing on antibiotic prescriptions. Specifically, our primary outcome was change or cessation of antibiotics 24 hours from the test result, and other ancillary testing in the workup of a possible bacterial infection. So first of all, over 90% of our kids had a test done. So then we restricted our analyses to those patients who did have the test done, since almost the whole population did. And the NPA was positive in 92%. So again, we have a good method that can detect almost all the viruses that were causing infections in these kids. And the number one player was clearly RSV. Almost half of the kids had RSV. But a third of patients had antibiotics prescribed in a viral syndrome. And if you limit our analysis to those with antibiotics prescribed, there was really no difference in overall proportion of patients prescribed antibiotics in the patients who were positive in their NPA. Those were negative for a virus. Duration of antibiotic use was the same in both. And then looking specifically at antibiotics stopped within 24 hours of the result being available, 75% of kids with a positive NPA continued on their antibiotics, and there was not a statistical difference. And even if we had a study that was twice as big and we found that there was a statistical difference between positives and negatives, we still had to test 332 kids to maybe have 26 courses of antibiotics shortened. Maybe. Because some of those 26 was just, there's a change in physician and says, oh no, that patient doesn't need antibiotics, or the clinical evolution is not compatible with a bacterial process. So maybe 26 for 332 tests done. And then, so what is driving antibiotic use? Because it's not positive microbiology cultures. Only one patient had a positive urine culture. None had a positive blood culture. Well, it's the clinical diagnosis of either otitis media. And I don't know if anybody of you has tried to look in the ear of a young infant who's unhappy because they have a viral illness. It's not always easy. And the ears are going to look red anyways because they have a virus. So distinguishing bacterial from viral otitis is very difficult. And then the pneumonia, we've talked about how even on chest x-ray, how do you distinguish changes that are due to the virus that are part of bronchiolitis from a bacterial process? And what we found is that the take-home point from the x-ray data is that as soon as, obviously not having a chest x-ray done was less likely to get antibiotics, because there's an indication bias there. But having a normal chest x-ray decreased your risk of antibiotics, but most kids did not have a normal chest x-ray. So if you had a pneumonia only with finds like consolidation, pleural effusion, things that were compatible more with pneumonia and not bronchiolitis, that was the biggest risk for increasing your antibiotic use. But a lot of patients had findings that were both compatible with pneumonia and bronchiolitis. So things like collapse, atelectasis, hyperinflation, and maybe a consolidation. And really, how can you tell the difference between collapse and consolidation in a small baby's chest radiograph? It's not easy. And then even those with findings that were just bronchiolitis had an increase in the risk of pneumonia. So as soon as there's something on the chest x-ray, physicians are quick to say, okay, I can prescribe antibiotics in this patient because he's sick enough to get hospitalized. And something that a study that was led by Makeda Semret using a secondary analysis of a prospective cohort study on influenza, and Nandini did a lot of the work with Makeda on that, found something relatively similar in adults with our multiplex viral testing, that antibiotic prescriptions were not associated to test result, but they were more strongly associated with the chest x-ray result. So viral diagnostics is really only half the battle, maybe a third of the battle, I'm not sure, as the editorial pointed out. So what's missing? And those are the kinds of things that we're working on now. Biomarkers that reduce the uncertainty regarding a bacterial infection. Antimicrobial stewardship to have people say, hey, your patient has influenza and the chest x-ray doesn't look like bacterial pneumonia, maybe you can stop the antibiotics. An independent eye, looking at these things. Reducing unnecessary chest radiographs. And the CPS also says, don't routinely do chest radiographs in bronchiolitis. Why? Because you're going to find something and you're going to prescribe antibiotics. And then choosing wisely, who needs rapid tests? Whom is it going to benefit? Who needs respiratory virus testing? It's not the kids with bronchiolitis, but there may be other kids who do need it, in whom it is useful. Well, that is the problem, is that your X-ray shows pneumonia, but we don't have a microscope to go in there and say that there are, gram-positive diplococci causing that pneumonia, or it's all just the RSV or influenza. There's no way of really knowing. So maybe procalcitonin, for instance, has been shown in a recent meta-analysis of individual patient data to decrease antibiotic use in a procalcitonin guided algorithm in RCTs, and also decrease mortality. Now, where did that mortality decrease come from? Was it because of less antibiotic exposure, less C. difficile in adults? Was it because maybe the procalcitonin arm, they were really targeting the ones who needed the antibiotics, and perhaps more antibiotics were given to the patients who did require antibiotics? It's hard to say, but I really just put that up because my wife wrote the commentary. And just one last thing is, I'm like, I don't want you to take away from this that, why are we using multiplex PCR? We should stop it right away. It's expensive. We're doing 10,000 tests a year. It's useless. No. In the certain patient populations, it's not useful. But look at this example of a rhinovirus outbreak in our neonatal intensive care unit that before the multiplex PCR, we would have never been able to identify and take measures to try and stop the transmission of these nosocomial infections, and it was associated with one death. So, in summary, I'm not sure if this arm of my research program is going down a road to nowhere. Because honestly, when I started and I came from my research fellowship, I kind of felt, all right, I'm going to be working on clinical impact of respiratory virus diagnostics, among other things. I had the experience in the lab, and I work in the diagnostic lab. I see patients. It's perfect. Get a little bit of epi inside me, and I should be able to do something that's half decent. But I think that the tests are better. They're simpler. They're faster. They're more accurate. Now there are actually now tests that are approved for use. So CLIA-waived, that can target 12 different pathogens, 3 bacteria and 9 viruses. So the tests are getting better and better, but we need to know in whom should these tests be performed, and what is the clinical syndrome that's going to potentially benefit. I think they can't be used in a vacuum. In the same way that if you use procalcitonin without an algorithm to help you guide your antibiotic use, it's actually been shown that you might increase antibiotic use if you just use procalcitonin willy-nilly. So we need to have either other interventions, biomarkers, stewardship, things that we're trying to see if that impact can also improve outcomes.
Right now,
yeah. So, well, I guess part of the problem is I can't even, in terms of adherence to a protocol like that, if it was just respiratory virus identification, how can I tell the clinician that thing on chest X-ray is not bacterial? So even though it's probably viral, it may also be bacterial, and then there's a whole bunch of different things that could play into how sick the patient is, how high their fever was. So I think we need more than just identifying an alternate etiology. Okay, yes, it could all be viral. We found the virus, but now please make me less stressed about this being a bacterial infection also. So, either because a little bit of hand-holding with antimicrobial stewardship. Sorry, I don't mean to be condescending. Like an objective eye to look at the data and say, we really don't need to continue the antibiotics in that patient. Or something more objective like a biomarker, whether it be procalcitonin or something that's in development. And actually, we're still at the knowledge synthesis phase for that. So we're doing a couple of projects looking at the clinical impact of respiratory virus testing in hospitalized kids, or looking at rapid testing in emergency rooms. So Kim is actually working on the pediatric hospitalized patient systematic review, and I got a MSc practicum student who's going to be doing our ED project that we had submitted to CIHR for a knowledge synthesis grant. And we ranked well, but not well enough to get paid. So we're doing it on the cheap. So we're still kind of at that. I don't have enough evidence to really say that, I wouldn't feel comfortable doing an RCT in my emerge using whatever rapid viral test, and then trying to force clinicians to use less antibiotics based solely on that. So there's still a lot of groundwork that needs to be done to try and help us decrease the uncertainty or decrease the likelihood of a concomitant bacterial infection. And maybe some of it's just education. Like, stop doing, maybe in bronchiolitis, stop doing the chest x-ray unless you really feel that this patient has a high pre-test likelihood of pneumonia. A lot of the patients in our bronchiolitis study that had a chest x-ray didn't even have a fever, and they weren't going to the ICU, so it's not that they were critically ill and needed to take a look at their lungs from that point of view. Yeah, they're sick enough to be hospitalized, but, Oh, sure. Sorry. I'm sorry. No, actually.
Because antibiotic stewardship, that concept presupposes that doctors are giving antibiotics frequently when it's not indicated, and follow these guidelines. So then that implies a degree of certainty. And yet we're saying we can't really prove that the pneumonia is viral bacteria.
Yeah.
I mean, it could be the answer. I'm just trying to
So antibiotic stewardship is trying to optimize the use of antibiotics. So to give it to the patients who need it at the right dose, the right route, and for the right duration, and to make sure that there's an indication for the prescription as well. So not using it when not necessary. So stewardship can, when I do stewardship rounds in the ICU, sometimes I suggest broaden the spectrum, or sometimes I suggest add another antibiotic because this one's not cutting it. But sometimes I also suggest stop the antibiotic. The patient's doesn't need it. But I think what we know is, as a group, as a whole, acute respiratory infections are being treated with too many antibiotics. We know that they're getting. It's not 1/3 of our patients who are admitted with bronchiolitis who needed the antibiotics. There's a proportion, whether that proportion is 2%, 5%, 10%, I don't know. But it's a small proportion of all that. But who is it exactly? That's what we need to work on. And this is typical intensivist talk. We hear it all the time. I can't stop the antibiotics. The patient is too sick. But people also don't. But people don't. I think that is certainly, especially once if you've been burnt once, you're going to be. But people don't see the downstream problems with antibiotics. Yeah. Either the resistance or the acute kidney injury, or the C. difficile we might see, and then obviously in adults, people have got that has led to a conscientisation of regarding antibiotic use, or certain classes of antibiotics. But so CIHR has a call it just came out last week, for an antimicrobial resistant using point-of-care diagnostic assays. And so I've been thinking, okay, well, and it has to be matched with industry. So, for instance, Biostatistics has a 12-plex rapid test that can be used for in outside the lab setting. Biostatistics also happens to make procalcitonin, but it's a lab-based. Procalcitonin is a lab-based test. It's still $20, but then we don't have it. But then instead, what we're doing is we're using a white count to help us, which is completely useless. The area under the curve of a white count is procalcitonin is not perfect, but we're using other things that are cheap but not helpful. Yeah. So I don't know. I'm supposed to talk to them to see if they don't have a point of care version that is either in development or perhaps available in Europe or something. So that's it. I wouldn't even feel comfortable writing up a grant proposing a randomized trial that was just based on respiratory virus diagnostics. I wouldn't feel comfortable writing that up. That's it. There you go. Well, you have to have buy-in from the users. Yeah. Very interesting. Well, thanks.